Hi, this is Martin Gutenberger. I'll be talking to you about how to read and organize yourself when reading these whole body oncologic staging and restaging examinations. So the patient I have here today has metastatic colorectal cancer. It's important to know that when the oncologist is getting your report, for the initial study they just want to set a baseline. They want to know where the cancer is, to kind of determine whether the patient's a candidate for surgery or anything. But once the patient has kind of been determined that they are going to get chemotherapy, if they have widespread metastatic disease and they're not going to get treated, generally what happens is the oncologist wants to know, is the patient better, worse, or the same? And there are a few different ways that can be done. The most common way, especially for research, is something called RECIST, which is Response Evaluation Criteria in solid tumors. And basically for RECIST, what you do is you measure the longest dimension measurement in up to 5 lesions. That's in up to 2 lesions per organ. And then you follow those same lesions while the patient is on the same chemotherapy. And after they get treatment, hopefully those lesions shrink, and the smallest those lesions ever get is called the nadir. And then after the lesions have shrunk and reached their nadir, if they start growing again, once they've grown over a certain threshold, the patient will be determined to have failed that treatment, and they will go on to another treatment, and that's called progression. They don't have to change the patient's chemotherapy if the tumors have grown by a certain amount, especially if there's not a good alternative treatment. So generally, they don't like us to use the word progression because to them that kind of implies this treatment has failed and you need to change something, and they may have good reasons to not want to change it. So generally when we're restaging these, we just say, overall the tumor is generally increased or decreased or stable, or there are variable changes as described. Generally that's the verbiage. We usually don't use the words progression, just because the oncologists sometimes feel like that forces their hand. So that said, we're going to look at this examination, which is from October of 2018 in this person that has metastatic rectal cancer. You would do the same search pattern as you would for chest, abdomen, pelvis, and see those videos if you want to know the search pattern. And while you're doing that, you're going to find lesions that you think are cancer. So we're going to pretend that this CT is the first examination this patient's had, at least with this. They're just going to start a new chemotherapy. So we're looking for lesions that would be a good baseline to follow to see if this chemotherapy is working. So we see a left supraclavicular metastasis here. We see a few other small upper mediastinal nodes, and then we have these larger mediastinal nodes. So those are all metastatic. The patient also looks like they've got some lung metastases here, and they have a pleural effusion. Nothing to say that that's a malignant or benign effusion, but we've got all of these pleural metastases here. Coming down to the liver, we've got some liver metastases, and then they have some metastases in their anterior abdominal wall. So now we need to decide what metastases do we think would be easiest to follow in the future, which is a little bit hard because you don't know which ones are going to get bigger or smaller, or be hard or easy to measure in the future. This pulmonary metastasis, for example, this actually used to be a lot easier to see, but now it's surrounded by atelectasis because it caused obstruction, so it would not be a good lesion to measure. But this lymph node here, this prevascular lymph node, this is a good lymph node to measure. It's got nice fat planes around it. It's not too hard to measure. I think there's a good chance that from person to person we would all measure this the same. And so what you're going to do is you're going to pick the single longest axis diameter for RECIST criteria, and just measure from edge to edge of the lesion. So here I'm getting 2.8 centimeters here. Sometimes we will measure things bidimensionally, so you measure in the long axis and then you measure in the longest perpendicular line to that. That's not required by RECIST, but sometimes people prefer bidimensional measurements, and so a lot of times we just include them to avoid emails asking for more measurements. So there's one lesion we decided, this lymph node. Then I would pick probably 2 lung nodules. Say, for example, this lung nodule here. we could measure. Let's say that that's 1.4 centimeters, and we can pick another pulmonary nodule that we think would be easy to reproducibly measure. How about this one? Say that's another 1.4 centimeter nodule. And then we can pick some liver metastases. So there's one. This one's already been measured, 3.7 by 3 centimeters. And then for our final lesion, we'll go down and we'll measure this anterior abdominal metastasis. And all of these things are big enough. Generally for RECIST, you want something to be larger than 1.5 centimeters. And I think that they'll be reproducibly measured. Things that are not good index lesions would be things like malignant ascites or fusion, because it's hard to measure those things. You're looking for solid tumor. Bone metastases also are hard to measure unless they have a significant soft tissue component. So now we're going to fast forward into the future here, and 3 months later this person is here for restaging. So we're going to read the whole study just like we normally would, but now we've got to decide whether our index lesions are bigger, smaller, or the same. So here we've got our prevascular lymph node, which we measured before. Our long axis diameter went from 2.6 to 2.8 centimeters. Our liver metastases, our single one here, it used to be 3.7 centimeters, now it's 4.9 centimeters. Our pulmonary metastases, we would measure those as well. We'd try to find the exact same ones that we measured last time. That one and that one. And we'll see if those are larger. And then we'll measure our anterior abdominal wall metastasis. And that one is now 5.9 centimeters compared to 5.4 centimeters. So all of our index lesions have increased in size. So the patient has failed treatment. Again, I wouldn't say progression. I would just say interval increase in size of metastatic disease or increase in metastatic disease, and let the oncologist decide if they want to say it's progressed. And sometimes when it's obviously progressed, I will say progressed. This case, for example, the patient has new sites of metastases, and that even if the index lesions are stable, if they have new metastases, that is definitely progression. Now you have to be sure that there are new metastases. You don't want to have something that, maybe there's some little tiny nodule that could be inflammatory. You don't want to make that a new index lesion and call it a metastasis. But generally that is how we do it. And that's how we do it. And at the end of the examination, we will make a list of the index lesions. I like to put mine at the end of the report. So in this case, I had 4 index lesions: the anterior abdominal wall mass, liver metastasis, a pulmonary nodule, and a prevascular lymph node. And then I also just included some examples of liver lesions with their measurements. I don't usually measure anything else that I think is a metastasis in the body of the report. I'm just descriptive, and I say things are increased or decreased. And that's generally how I report things. I hope that it makes it easy for the next person to see exactly what I measured, what image number it was on, how big it was this time, how big it was last time. And I try to leave my markings on the images. And those are the things I try to do to make what can be kind of tedious and painful exams a little bit more organized. So, thank you.